So all set, should we start?
Yes, we can.
So good evening everybody, welcome to this evening episode of Pursue, and this is Pursue 6Y, which is liver and GI pathology, and we are streaming live from AIIMS New Delhi via Kolkata. And today we have two very special person and a very, very important topic. So I would take the honor of introducing the moderator. Today's moderator is a very well-known person who we all know her as Amita D. She's Dr. Amita Majumdar Giri.
Good evening.
She's a postgraduate from IPGMER. Presently, she is the professor and head of AIIMS Haldia. Also, she is the principal of AIIMS Haldia. She has been in the position of professor and head in various medical colleges in West Bengal. She is also an empaneled national internal and external examiner for undergraduate, postgraduates, and DNB. She is also the MCI assessor for UG and PG inspection. She is also the president of the APMWB, which is Association of Pathologists and Microbiologists, the West Bengal chapter. And she has the honor of hosting two annual state conferences, one in North Bengal and the other one in National Medical College. A very, very well-known person in the pathology circle. And so we have a relationship between the teacher and the taught today. But before I ask Madam to introduce the speaker, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. With this, I would request Dr. Amita, ma'am, please introduce the speaker and let us start from there. Thank you so much.
Good evening. Thank you, Dr. Nadim, for your kind words. I don't think I deserve all those things, all the adjectives though. Today we are honored to have Dr. Prasenjit Das with us. He is an additional professor in the Department of Pathology in All India Institute of Medical Sciences of New Delhi. He is an alumnus of Calcutta National Medical College, Kolkata, and the Postgraduate Institute of Medical Research and Education of Chandigarh. He is a visiting pathologist at the Beth Israel Deacon's Medical Center and Harvard Medical School, Boston, under the Celiac Disease Joint Research Network, and for excellence sponsored by Indo-US Science and Technology Forum in 2019. His areas of research are gastrointestinal and hepatobiliary pathology. He has around 189 publications in international and national level peer review of journals with more than 101 original research articles to his name. He is also an associate editor of Indian Journal of Pathologists and Microbiologists. He is a member of many associations of pathologists and microbiologists of our country and abroad, all over the world. I am not going to name all those things, all the associations. So we are very proud to have him in today's session. Thank you, Dr. Das.
Thank you so much, Amita Madam, for these nice words and for the nice introduction in this forum. And I am really honored that Dr. Nadim gave me this opportunity to have a slide seminar. So first of all, good evening everybody. I will now share my screen. Give me a minute, please.
Yes, please carry on.
Can everybody see my screen now?
Yeah, it's clearly visible. Yeah, just press on that hide so that goes away.
Yeah.
Yeah, perfect. Please start.
So actually this topic and this title was decided by Dr. Nadim, and as you will everybody knowing him, The title I did not select. It is so promising title. I don't know. With liver biopsies, we always can achieve that promise and what this title actually is conveying to you. But what I will do in the next 1 hour or so, I will show you some of the scan slides of the liver, and these are not extraordinary cases, but they will. I am sure that they will teach you how to approach some of the liver lesions what we commonly see. Okay, so with that introduction, I also know that you had some of the liver sessions previously also by Dr. Kakkar and others. So I know that you know the basis of liver biopsy interpretation, but I will take 2 to 3 minutes just to give a brief introduction so that people who did not earlier attended those sessions, they can also have a basically sense of this liver biopsies.
Can I interrupt? Can I interrupt
Yeah,
a
please,
minute?
please.
I cannot see your screen. Please.
No, the
Dr.
screen
Nadu,
has gone away. The screen has gone
please.
away.
Okay,
I think Dr. Prasenjit has to re-present.
Okay.
Okay.
Mm.
I would request everybody, please don't share your screen. Only Dr. Prasenjit will share the screen.
Okay.
Can you see now?
Yeah. Just make it full screen. Yeah, make it full screen.
If you just help me, how can I share?
No, you don't need to share. You will see the screen. Just wait.
I can't see his screen.
What about the other people? Can everybody see the screen of Dr. Prasenjit?
Yes, sir. We can see the screen of Dr. Prasenjit, sir.
You can see. Then, ma'am, can you see, madam, Dr. Amitadi?
No, it is. I can see Dr. Prasenjit, but not his screen.
Okay, then there is some setting issues in your system. You need to just sort that out.
Okay, yes.
You can do one thing. You can just log out and then log in. It will automatically get sorted out.
Okay.
Sorry for that.
Let's carry on.
So can I go ahead?
Yes, Dr. Das, please carry on.
Sure. Okay. So whenever we talk about a liver biopsy, the most important word we use that if the lobular architecture is present or not, or maintained or not. What is a lobule? You all know lobule is basically polygonal shape like this. At the center there will be a central vein, and all the corners there will be multiple portal tracts. So if you see in a core biopsy of liver, the central vein and the portal tracts, they are widely situated, and they are not connected by fibrous tissue, or they are not crowded to a single place. So you can take it that the liver lobular architecture is maintained. You also often use a word that is hepatic acinus. We call the acinar architecture is normal or abnormal. And what is the acinus? In the acinus, in contrast to the hepatic lobule, in the center there will be a portal tract. It is a rhomboid shaped structure. Okay, and at the end or at the corners there will be the central vein. Okay, so that this is the basic difference of acinus, and this acinar structure was described by the Rappaport to describe the functional or metabolic zones of the liver, and accordingly you all know the blood is supplied mostly from the portal vein and hepatic artery towards the central vein. So accordingly it was divided into 3 zones. The zone 1, the periportal hepatocytes, zone 3, the centrivenular hepatocytes, and in between there is zone 3. So while we will be discussing the liver biopsies, we will use these words, that is the hepatic lobules and the zones of the liver. And everybody of you know that what a normal portal tract look like. It has a hepatic artery, which has a muscular wall. It has a largest vascular structure, which is the portal vein. Its wall is not thickened, and in addition, we see 3 to 4 or 2 to 3 at least branches of the bile duct. Okay, the hepatocytes, they are highlighted by CK8 stain. On the other hand, the bile ducts and in branches can be highlighted by CK7 and CK19 stains. Now, another important thing is, this is a portal tract. You can see all its normal structures, and these are the hepatic cords, which is actually arranged, which is going away from the portal tract. The last layer of the hepatocytes, which is basically walling the portal tract, that is called the limiting plate. This is the most important structure we have to see. Normally, there are lymphocytes in the portal tract, but when this lymphocytes crosses this limiting plate and it goes into the adjacent hepatic lobules, infiltrate the lobules and induces apoptosis in these cells, that is described as the interface hepatitis. So it is another important changes or pathological changes that we'll see in many of these liver biopsies. Okay, so to call something about limiting plate, you have to see if this junction is straight or it is irregular like this, as if something or somebody has eaten this in piecemeal or nibbled it. That's why previously we also used to call it a piecemeal necrosis. So this is another example of a liver biopsy in high power. You can see very irregular and slightly fibrous portal tract. There are a lot of inflammation. And if we try to see this junction or the limiting plate, you will automatically see, if we try to trace it from here and from here also, it is very irregular. All these lymphocytes, they are going into the hepatic lobules. So you can clearly say that this liver has interface hepatitis. Okay. In addition, if you concentrate in this area and here also, you will see some of the acidophil bodies. So by definition, you have to see some of the acidophil bodies along with spilling over of these inflammatory cells into the hepatic lobules. So what does interface hepatitis tell us? So if in a liver biopsy, if you see fibrosis or interface hepatitis, these changes will tell you that the liver is showing some of the chronic hepatic changes. Okay, so chronic hepatitis is characterized on histology by either fibrosis or interface hepatitis. But some of you may ask me that if interface hepatitis is also seen in acute hepatitis, we can see lots of inflammatory cell in the portal tract in acute hepatitis also with interface hepatitis. But in addition, in chronic hepatitis, the main focus of the inflammatory cell infiltrate will be in the portal tract, while in acute hepatitis, there will be lots and lots of inflammatory cell infiltrate will be in the hepatic lobules, in the hepatocytes. Okay. Now, before we go into the cases, you should know that while a clinician is doing a liver biopsy and sending it to you, they already know that it is either a chronic liver disease or chronic hepatitis. So what is his expectations? The expectation is you should confirm if the chronic hepatitic changes there or not. You have to adopt a systemic approach to reach to and to give them an etiological diagnosis, because there are some diseases like autoimmune hepatitis where serology is not always very high. In 30 to 40% cases, the serology is not, serotiter is not very high, but histological changes are quite suggestive of autoimmune hepatitis. So etiological diagnosis they expect from you. You have to also tell what is the severity of the necroinflammatory activity. That means you have to grade the inflammation and the inflammation related changes, and you have to also stage the fibrosis. Okay, so you have to do it all liver biopsies. Most importantly, you have to rule out any comorbid diseases are there or not in the liver biopsy. You have to rule out if there are changes of the acute and chronic liver diseases or chronic liver failure, and rule out cirrhosis in vascular liver diseases. I will give you some of the examples. And everybody of you know that very routinely in all cases we use multiple stains like reticulin stain. Reticulin stain basically highlights the type 3 collagen which is laid into the space of Disse. These are the fine fibers, they are not straight fibers, they are arranged in a checkerboard like pattern, and all the sinuses or sinusoids you know, they connect each other. Okay, so if you see in a liver biopsy, the portal this reticulin fibers are becoming stiff and thickened and parallel to each other in a place that indicates there is reticulin fiber deposition. MT, you know, the collagen, it stains the collagen. It can be either blue or it can be green based on what stain has been used. Serious red also stains the collagen. These are the mature collagen markers. Okay, and orsin. Orsin, you can identify the elastic tissue. Here in the portal tract, you can see deep cola color stain. Also, it can highlight the hepatitis B surface antigen or the copper associated proteins. So with that, I will go to the case number 1. And I am sorry that I have to in between go into the other softwares to show you some of the scan slides. Okay. So the history is, this is a 22-year-old male incidentally detected to have hepatitis B surface antigen. His serum hepatitis B core antigen was also positive and anti-HBe antigen is negative. Liver, AST and ALT, ALT was about 93 and AST was high. It is almost 5 or 6 times higher. Alkaline phosphatase is within normal limits and there is no feature of clinical hepatic decompensation, and they did a liver biopsy. Can you see the scan slide now?
Yes, sir, we can see the slides.
Okay, okay.
Yeah, we can.
So now we were talking about first lobular architecture. So we'll see if the lobular architecture is present or not. That is the that we have to see in low power. Here you can see this is possibly a portal tract. This is another portal tract, and this may be a central vein. These are portal tracts. So as I told you, you have to eyeball or you have to go through all the codes, whatever is there in your biopsy, and you have to see if somewhere there is crowding of these structures or they are connected with each other by any fibrous band. I cannot see that, so I can think that the lobular architecture is preserved. The next thing I have to see on higher power is the portal tract. So in all liver biopsies, we have to start from the portal tracts. So this is a portal tract. You can identify all the structures, and a portal tract is defined by presence of hepatic artery. You must know, because there are diseases, you know that the bile duct can be absent, or there are diseases where the hepatic portal vein can be absent. Okay, but usually hepatic artery is the structure which remains there, and it defines the portal tract. Okay, so what we can see, there is only mild or sparse inflammatory cell infiltrate, and only an occasional lymphocyte is going into or spilling into the adjacent lobules. Let us see the other portal tracts. This is a part of the portal tract. The inflammation is very mild, and this is another portal tract. You can see very sparse inflammation. We can see one of the bile duct which is quite patent. Here also you can see mild inflammation, and it is spilling into the adjacent hepatic lobules. So what is important, you have to now define or you can imagine this line, this limiting plate, if it is straight or not. So I told you, you have to trace it like this as the inflammation is coming here. So possibly this area is possibly nibbled or irregular. So you can say there is mild focal interface hepatitis, and there is some spotty necrosis here. What else? We can see some of the macrovesicular steatosis here. I cannot see any significant cholestasis. Okay. Let us see what else is there. So these are the steatosis we have already described. See, this is the balloon hepatocyte, okay? That means balloon hepatocyte, what does it indicate? It indicates that there is some liver degeneration or hepatocyte degeneration which is going on. This is a spotty necrosis. Spotty necrosis is defined by infiltration of a few lymphocytes around a 1 to 2 hepatocytes, okay? And you will see also the feature of hepatocyte degeneration in the form of either ballooning or feathery degeneration, or there can be acidophil bodies. In addition, see, there is some other changes, like it is becoming slightly, because I am presenting today from my laptop. So what you can see the color of the hepatocytes, compare this with this. You can see some of the hepatocyte, the cytoplasm is quite glassy, okay? I will show you some of the pictures I have already taken for you, so that there is no problem. See, these are the normal hepatocytes. I told you the normal hepatocytes are polygonal in shape. You will see multiple angles. So balloon hepatocytes, when these angles are lost and the hepatocyte become ballooned and the cytoplasm become cleared. And in addition, I showed you some of these are the balloon hepatocyte. I showed you focally the hepatocytes are showing some of the glassy appearance of the cytoplasm, and very focally there are changes of the spotty necrosis. But most importantly, we cannot see any cholestasis in this liver biopsy, and we cannot see the significant fibrosis. For that, we'll use reticulin stain and empty stain, obviously, but we can also identify if the portal structures are expanded and there are fibrous bands which are coming out. So there are nothing actually. These are the areas of spotty necrosis I have showed you. So with this, what maximum we can say, unless we do some ancillary stains, most possibly this is mild in chronic hepatitis, okay? And we have to see what these ground glass changes are actually there, okay? So I am going to the presentation again. So these are just to summarize, we saw these portal tracts with interface hepatitis very focally, and here you can see in the centrizonal area or in the zone 3 there is macrovesicular steatosis, which was comprising about 20% of the core areas, and this is to show you the interface hepatitis. And I was showing you these changes. See, these hepatocytes normally they are polygonal in shape, and you will see the granular cytoplasm, but here the granularity has been replaced by this type of glassy inclusions, and they are surrounded by clear halo, okay? So it is very important to see this clear halo. And why? So how to approach? Most importantly, I was talking about you have to see the portal tracts first, and you have to see the inflammatory cell infiltrate is there or not, and also you have to identify the interface hepatitis. Always remember that the Ishaq's modified grading system or the necroinflammatory grading system what we use, it asks you to grade the inflammation in the portal tract and inflammation in the surrounding area of the portal tract. That means interface hepatitis, okay? So most importantly, you have to see if all the portal tracts are showing inflammatory cell infiltrate and they are equally involved or not. See, in this biopsy, in this example, these two portal tracts are showing moderate inflammation, but other areas the inflammation is very less. So you will tell it, you will call or you will say that in these biopsies, the portal tracts are showing moderate inflammation, and that too focally the portal tracts are involved. Another example, see this liver biopsy core. Here also you can see one of the portal tract is showing moderate inflammation or moderate with interface hepatitis, but the other portal tracts are not that much involved. So this is also focally involved. If you see, go through the grading system, see mild inflammation or inflammation is moderate, and in moderate, if all the portal tracts are involved or the inflammation is marked and that is involving all the portal tracts are involved, accordingly you have to grade it. But apart from grading, the most important thing is to reach to a etiological clue, because that is expected from you, I already told you, and the density of the inflammation will actually help you to narrow down some of your differential diagnosis. Just compare this picture with the other three pictures. That is the basic difference. Here you can see that is interface hepatitis, but that is mild, and the inflammatory cell infiltrate, that is also not very dense. It is maximum mild to moderate. But all other three portal tracts, all three liver biopsies, they are showing dense inflammation with this is important. You always remember that in chronic hepatitis B, if it is not complicated with any other coexisting diseases like chronic hepatitis C virus infection or with coexisting autoimmune hepatitis, the inflammation will be always mild to moderate. In NASH also similarly, if it is not complicated, the inflammatory cell infiltrate will be mild to moderate. And in resolving hepatitis of autoimmune hepatitis or some viral hepatitis, when the inflammation is or the severity of the inflammation is coming down, then also you can see less inflammation. However, if you see this type of moderate to severe inflammatory cell infiltrate, you have to think of first if it can be chronic hepatitis C or it can be chronic hepatitis C or B. You have to always rule out autoimmune hepatitis if the inflammation is dense. You have to also think of drug-induced liver disease, and you have to also think going to high power and look at their morphology. You have to see that if there is any lymphomatous infiltration. Okay, so is that clear? You have to see the density of the inflammation to differentiate between if it can be uncomplicated chronic hepatitis B or NASH from all other etiologies we are discussing. Now come to the ground glass hepatocytes. I showed you, but this is the click picture. You can see now clearly, but these are the ground glass hepatocytes, okay? And they will be surrounded by clear halo. This is very important to identify, otherwise there will be a mistake. And there was mild interface hepatitis, I already told you. But always remember, ground glass hepatocytes, this type of classical distribution is usually seen in chronic hepatitis B, but you have to keep in mind that in glycogenosis type 4 or in some of the drugs like cyanamide, which is given as an antidote of alcohol abuse or chronic alcoholism, or chlorpromazine or diazepam, barbiturate, or the patients who are taking IV insulin or glucose therapy, there you can see this type of ground glass changes. But the distribution slightly differs, and in most of these cases drug-induced ground glass changes, they are mostly seen in the zone 1, that is around the portal tracts. Okay, this is showing cyanamide. I borrowed it from one of the journal, ground glass changes associated with cyanamide induced change. Okay, now in this ground glass change are actually hepatitis B surface antigen which are started inside the lysosome of the hepatocyte cytoplasm. So they can be highlighted by your Orsin stain, or you can also use Victoria blue, or they can be highlighted by immunostain for the hepatitis B surface antigen. Now whenever you will suspect any chronic hepatitis B virus infection in your liver biopsy, you have to perform two stain. One is surface antigen, one is core antigen. What is the purpose? Their pattern of positivity will tell you what is the nature of the viral replication now. Okay, like if you see here, you can see the positivity is in the membrane, and as well as in addition there is positivity in the cytoplasm also. The dictum is if the positivity is diffuse and membranous, that indicates active viral proliferation. If the positivity pattern like this, like that is both diffusely membranous and cytoplasmic, that also indicates active viral replication. But if you see the positivity is patchy and is only at the cytoplasm, then it usually indicates there is no active viral replication. And this type of positivity also correlates with the nuclear positivity of the hepatitis B core antigen. Okay, I see if you do. Always remember, if you see nuclear positivity along with cytoplasmic positivity, that indicates active viral replication. If you see only cytoplasmic positivity, that has no significance for your interpretation. Okay, so you have to see both nuclear and cytoplasm or only nuclear positivity. But why I am showing this biopsy? To highlight one of the points I already showed you, that you have to always look for other conditions in your liver biopsies. So I told you the serological data also indicated it may be a chronic hepatitis B viral infection. The clinician also knew, but there was something else. That's why they did this biopsy. And you can see all this macrovesicular steatosis. This is macrovesicular because this is a big one, and this is just pushing the nuclei to the periphery, and there are some small vacuoles which actually coalesce to each other and form these large vacuoles. Okay, so there is no microvesicular steatosis here, and that is away from the portal tract. That means they're involving the zone 3 and zone 2. This type of distribution is also quite suggestive of NAFLD associated changes. But you remember that 1/3 of the chronic hepatitis B, the liver biopsies from the chronic hepatitis B can show you steatosis. And in 90% instances, this steatosis is actually macrovesicular in type, like that you are seeing in this liver biopsy. And in 60% of these cases, the distribution is towards the centri lobular area, or in the zone 3 distribution, which actually we see in alcoholic and NASH related changes. Because if you see what is the pathogenesis of this fatty change in chronic hepatitis B patient, you will see there is actually no association with genotype, because this study is an Indian study, and you can see in India these two genotypes are the most common, genotype D and genotype A, and there was no difference of distribution of these fatty changes between these genotypes, but rather these changes were associated with the high serum triglyceride and high cholesterol in the patients with fatty changes. So actually this chronic hepatitis B with with macrovesicular steatosis in the liver is actually related to the metabolic changes, or metabolic changes. Okay, so you can see also steatosis in chronic hepatitis C, but that is irregular. That will be not classically restricted to the zone 3 and zone 2, like what I have already shown you. And always remember, I told you the inflammation is mild to moderate in chronic hepatitis B, but not in chronic hepatitis C. Chronic hepatitis C, the inflammation is always moderate to severe. You can see lymphoid aggregates, and always you have to keep a differential of autoimmune hepatitis whenever you see chronic hepatitis C like changes. And see here, interface hepatitis is prominent, and there are regular macrovesicular steatosis. This is a hepatitis C associated cirrhosis. And in addition, in chronic hepatitis C, what you will see the lymphocytes are infiltrating the bile ducts. Okay, so lymphocytic cholangitis is not uncommon in chronic hepatitis C, and you can see regenerative bile ducts. So all these features will help you to think if it is chronic hepatitis C or not. Also remember, this type of steatosis which help us to basically identify chronic hepatitis C related changes that can be seen up to 40 to 80% cases, and it is not always metabolic related, but changes related. It can be also direct cytopathic, because this type of steatosis is more commonly seen in HCB genotype 3, which is also prevalent in India. So in chronic hepatitis C, always remember, if you see dense inflammatory infiltrate in the portal tract with interface hepatitis and irregular macrovesicular steatosis and some lymphocytic cholangitis, always keep in mind it can be chronic hepatitis C, and talk to your clinicians. Now, I told another important role of pathologists is to stage the fibrosis. We do staging only for fibrosis. There are 6 stages of fibrosis. In the stage 1, hardly we see portal tract expansion. In the stage 2, most of the portal tract showing expansion. Stage 3, along with expanded portal tracts, there will be thin fibrous septae that will come out from the portal tract. In stage 4, now the fibrosis is becoming more prominent, and these thin septae and occasionally they will connect one portal tract to the other. On the stage 5, they have become very thick, and you will see focally incomplete or complete nodule formation, but it is not diffuse. And in the stage 6 or cirrhosis, the fibrous bands are thickened, and you will see the nodules everywhere. Okay, so this is the Ishaq staging system, what we commonly usually use. But you can also use Metavir staging system. Metavir staging system was initially described for the chronic hepatitis C, but it can be used interchangeably as per your convenience for the all chronic hepatitis. Okay, but it has 4 score structure system. In the Metavir F1, you will see some expansion of the portal tracts, not much septae. In the F2, there will be some thin septae which will be coming out and connecting each other. In the F3 will be just like your Ishaq stage 5, and a Metavir F4 score will equate with your Ishaq stage 6. Okay, so you can use them interchangeably. So what is the final diagnosis of this case? We wrote it like this. This is a chronic hepatitis, obviously, because there was not much fibrosis, but there was interface hepatitis. We identified hepatitis B virus related ground glass changes, as well as the antigen was positive. So it is HBV related with mild macrovesicular steatosis. Actually, in the report, you have to also mention how much or what is the percentage of steatosis and distribution. And we told them, kindly investigate further to rule out coexistent NAFLD. So this should be the final diagnosis from this case. So what we learned? We learned that paying attention to the density and distribution of the portal inflammation will help you to narrow down the histological differential diagnosis. Okay, you will agree with me, and always look critically to exclude a coexisting liver disease. You don't just overlook those fatty change, because always remember, chronic hepatitis B, it will require 15 to 20 years if the patient to go into the cirrhosis stage or so, or another 10 to 15 to 20 years to develop HCC if at all. But you remember, always if the NAFLD is not looked into or not taken care into, then the progression will be much faster. The patient may go into cirrhosis maybe in next 5 or 10 years. So I think this is all about case 1. So if there is any question. So can I go to the next case?
Yeah, please.
Okay. So now we are going to case 2. Case 2, this is the history, 30-year-old male, known case of chronic liver disease. They already knew this is a chronic liver disease. That means they must have seen some fibrosis or irregular nodular appearance of the liver on ultrasound. But the patient died on day 3 of admission. He was admitted to AIIMS. All the viral markers were negative. However, ANA was 1:80 and serum IgG was 2 unit per DL. And in adult, you please remember this, the upper cutoff, it varies actually according to age, but it is about 1.6 unit per DL. And they sent the liver biopsy for opinion. They did not have any differential diagnosis. So we'll go to the scanned image. Okay, so now I hope you can see the liver biopsy. Yeah. In contrast to the previous one, what it is appearing, the architecture is preserved or not, see very closely. Whenever there is fibrous band which are connecting each other, okay, the bands are quite thickened, so you cannot identify which one is portal tract or which one is central vein. So obviously the architecture is distorted. This word distorted architecture is basically synonymously used with cirrhosis, and when there is mild fibrosis or mild irregularity or disarray of the ovular architecture, we use the term disarray of the architecture. Okay, and you can see the fibrous bands are quite thick and there are a lot of inflammation. Okay, and the size of the portal, the size of the hepatic lobules which are there, they are of variable size. And see, there is paraseptal interface hepatitis. The inflammation is still coming into the hepatic lobules. If you further go into high power, what you can see, these are the bile ducts. Okay, and these are the bile ductules. What is the basic difference between the duct and ductules? Because I have seen our students also use them very interchangeably, but they are very specific ones. Ductules you will always see at the interface. Okay, it is a basically a result of the interface hepatitis. If there is inflammation or interface hepatitis, then the cells at the canal of Hering, they will form both hepatocytes as well as newer bile ductules, and in the ductules you will see this type of structure and you will not see any lumen. But in the ducts, if you see a duct, you can clearly identify lumen like this. Okay, and there will be more towards the center, and there is lot of inflammation we can see. And what else? Let us go into further high power. So these are some of the hepatocytes, and these are the bile ducts. See the lining cells of the bile ducts, they are showing relative or really very regenerative changes. If we go into the hepatocytes are showing focal ballooning, and these are the nuclear glycogenization. Okay, almost like any nuclei. This is nuclear glycogenization. They are also not very specific, but they may indicate there is some metabolic change. These are the bile ductules. Okay, and some of the bile ductules are dilated, and inside the ductule you can see there is bile plugs. So it has a specific interpretation, and there is also some cholestasis in the hepatocyte. This is called canalicular cholestasis, and some of the hepatocytes are undergoing necrosis. Remember, this is post-mortem biopsy. I already told you that there are many apoptotic bodies, and focally there is confluent necrosis. Okay. What else? This is another area of confluent necrosis. This is showing some nuclear glycogenization. Let us see which type of inflammatory cell infiltrate is there, and we can see mostly there are lymphocytes, occasional polymorphs, and these are feathery degeneration. Feathery degeneration is nothing. The shape will be just like your balloon hepatocyte, and feathery degeneration, this term is only used when there is associated anatomical changes associated with your bile salt. Okay, so whenever there is cholestasis, you will see feathery degeneration, and there are some irregular macrovesicular steatosis. I will show you some of the click picture. I found focally there are plasma cells also, like this one. I think you can see there are some plasma cells here and there. Okay, so plasma cells are also there. So so if we see, so we are sure this is showing cirrhotic changes, and in the fibrous septae, if you see lot of inflammation, that indicate active inflammation. So the basic or the baseline diagnosis is cirrhosis with activity. Okay, it is active cirrhosis, and these are the plasma cell. And I have already shown you these are the lymphocytes which are infiltrating the bile ducts, and I showed you some of the bile ducts are showing marked regenerative changes. See this bile duct, this is one bile duct, vacuolation with lymphocytic infiltrate. So lymphocytic cholangitis I showed you in chronic hepatitis C. This it is very hard to think of chronic hepatitis B in this biopsy, because there is a lot of inflammation. There are a lot of plasma cells in this case with lymphocytic cholangitis. Okay, and we can see, if we go into some of the portal tract, what else you can see? You can see somewhere the hepatocytes are showing some of the acinar transformation. Acinar transformation are nothing. These are basically glandular arrangement of the hepatocytes, and this is nothing. This basically indicate a degenerative change. But in autoimmune hepatitis, they are seen more prominently, but it is not sine qua non of the autoimmune hepatitis. And if we see again, some of the lymphocytes will be seen in the hepatocyte cytoplasm. They are possibly traversing the hepatocyte cytoplasm. Okay, I will show you some click picture. They are easy to show you, and there are changes of hepatocyte damage. So what we should think of? So I showed you this one. I am going ahead. So I showed you this type of ballooning changes with acinar transformation with lot of inflammation, interface hepatitis. You always remember, and the inflammation is always dense. There is lymphocytic cholangitis, and I showed you these plasma cells. Okay, see this. This is one blood vessels, and this is showing marked endothelial swelling with lymphocytic infiltration. So this is basically endotheliitis. So it is not that only in setting of transplant we see this type of endotheliitis. In autoimmune hepatitis also you can see this type of changes. So this is ballooning change, and this is actually called called emperipolysis. If you see the hepatocytes here into high power, see here also you can see emperipolysis. The people has studied and they have said emperipolysis is one of the important diagnostic feature of autoimmune hepatitis, along with all these features what I just showed. And you must not forget this slide. I already told you, whenever the inflammation is dense, you should not forget two things in your routine practice. One is chronic hepatitis C, other is autoimmune hepatitis. So if we see the density of the inflammation in the particular case, what I am discussing, the inflammation is just like this, along with there are other features which will tell you possibly we are dealing with the autoimmune hepatitis. See, normally when there is inflammatory cell failure in the bile duct, sometimes you can see the lymphocyte directly, or in other cases you can see this type of marked regenerative changes that also will indicate there is bile duct injuries. Okay. So cholangiopathy or lymphocytic cholangitis in a background of hepatic picture, where we can see already we have discussed chronic hepatitis C or autoimmune hepatitis, it can be seen drug induced or transplant related changes. Okay, so this is by Dr. Dhantwar Chan, a nice study. They basically studied what are the changes of that define basically with dense inflammation. We will consider both of these differential chronic HCV and autoimmune hepatitis. See, plasma lymphocytic infiltration, that is plasma cell rich inflammation, is much more in autoimmune hepatitis. You will see rosette formation and acinar transformation more in autoimmune hepatitis. Emperipolysis more in autoimmune hepatitis, and inflammation grade is much more in autoimmune hepatitis. Okay, and plasma cell cluster. Plasma cell cluster means that they are defined by cluster or cluster of more than or equal to 5 plasma cells at a place. Okay, so that is also, if you see too many plasma cell cluster, that also is indicative of autoimmune hepatitis, and endotheliitis is also more common features of autoimmune hepatitis. Okay, so this is one just to show you some plasma cell clusters here, and maybe some of the plasma cell are clustering here. So if you see too many of this, you can think, along with dense background of inflammation and autoimmune and lymphocytic cholangitis, that it can be autoimmune hepatitis. Okay, acinar arrangement of the hepatocytes, I told you, we can see in the zone of injury, that is around the paraseptal area, but in some of the autoimmune hepatitis, we can see diffuse arrangement of the acinar transformation, okay, diffuse distribution of the acinar transformation. Acinar transformation diffuse, we can also see in some of the metabolic diseases. You must not forget, like in tyrosinnemia, there will be a lot of fibrosis, and in galactosemia. Along with this acinar transformation, you will also see a lot of fatty changes and bubbly changes and cholestasis. So these are the 3 or 4 differential diagnoses. You see a lot of acinar transformation of the hepatocytes. Okay, Dr. Jain in another paper, they described another characteristic feature of the autoimmune hepatitis. To be very honest, we don't see this type of changes. I cannot explain why their patients, they can see this type of Kupffer cell hyaline globules. We don't see. These are the past 10. They are supposed to be past positive and diastase resistant, and they have shown lot of this type of Kupffer cell hyaline globules in their biopsies of autoimmune hepatitis. They also found some in their chronic hepatitis C patients, but they found this is much more in autoimmune hepatitis, but we don't see, to be very honest. Like here you can see Kupffer cell hypertrophy, but there is no of these globules. So always, while you are making or suspecting a case of autoimmune hepatitis, you have to use this modified international AIH group criteria, and they say that your patient, there should be autoimmune marker should be positive. In this case, ANA was more than 1:80, IgG was I think it was more than 2. What I remember, I told you. And if you see, this case had typical features of autoimmune hepatitis, all the features, 4 or 5 features what I showed you, they are all present in this case. So accordingly, if there are only few or you are suspecting, they can be, but it is not, I am not sure. So you have to give 1, or if you are sure like this case, you have to go score 2, and if you have to demonstrate absence of viral hepatitis by your virology marker studies. Okay, so in this case the overall score was around 8, and if it is more than or equal to 7, then you can diagnose it as a definite autoimmune hepatitis. Now, we have already told this patient had Ishaq stage 6 fibrosis and Metavir F4 fibrosis, okay, that is cirrhosis. But we have to do a lot more. What else you have to do apart from identifying cirrhosis with activity? If you look into the paper published, this is basically a landmark paper by the LENAC group. What they identified that the patient's prognosis depends on the size of the nodules, residual nodules, and the thickness of the this fibrous band. Okay, so logically what happens as the residual hepatocytes or the nodules regresses, the thickness of the fibrous bands will be increased. That means more thickness of the fibrous band, there will be less functioning hepatocytes. Yes. Okay. So what the LENAC group did, they further classified or subclassified the cirrhosis into mild cirrhosis, moderate cirrhosis, and severe cirrhosis. Mild cirrhosis means most of these nodules will be large and the fibrous septa will be thin like this. Okay. In the moderate cirrhosis, there should be at least 2 thick bands like this, and in the smaller nodules or the micronodules, they will be less than in the 50% of the biopsy course. And severe cirrhosis, when there will be much more thickened fibrous septa, and most of the liver biopsies is showing you this type of small hepatocyte residual nodules, that will be severe cirrhosis. That means there is less functional liver, and the nodules are called large when they are more than 2 millimeter and small when they are less than 1 millimeter. And septae, when they are more than 0.2 millimeter, they are called thick, and septae which is less than 0.1 millimeter, they are called thin. So in this case, the LENAC cirrhosis score was 4B, that is, it is not so good. What you can do further, you can also resort to this PIR scoring. This PIR scoring is basically scoring of the fibrosis pattern based on their thickness and appearance. See, progressive septa is always thickened like this, and you will see there are multiple bands of fibrous septa. In between there are RBCs, or there are some residual hepatocytes. You will see like this. And regressive septa is always very condensed and they are thin like this. Okay, so this is progressive and this is regressive. So in their liver biopsy, what we can see, the fibrosis can be predominantly progressive, or it can be predominantly regressive, or it can be intermediate. This group, they basically studied, compared the fibrosis pattern between pre-biopsy and post-biopsy in their patients who are treated with severe, and they found that the patients, when there is progressive fibrosis, there was absolute advancing of the fibrosis in 2 out of 3, and the biopsies which were initially showing regressive type of fibrosis, there was absolute reversing in 29 out of 33. That means if you resort to this PIR scoring, you will also give a substantial prognostic information to the clinician. That means if your liver is predominantly showing progressive fibrosis like our case had, or your biopsy is showing regressive fibrosis, so that they can say, or they can apprehend that their patient is going to behave in a good manner. Also, Dr. Dhanpal Jain and their group, this is Jain Garcia system. They basically taken the further subclassification of the cirrhosis further. Okay, they included the clinical appearance of the, or clinical picture of the patients, like compensated cirrhosis or decompensated cirrhosis, HVPG, hepatic venous pressure gradient. They classified histology. I have already told you, histological score is basically, see the LENAC system, they have given a scoring. Okay, 4A, this is giving 4, moderate cirrhosis 5, and the severe cirrhosis 6. So accordingly, you have to do scoring if it is less than 4, 4, or more than 4 in these 3 types. And they have also measured the percentage of fibrosis. So based on all these 4 or 5 parameters, they further taken further this type of subclassification, and this was proposed, and we expect this to come in routine practice in the next few years. Okay, so we saw that our patient had cirrhosis, possibly had autoimmune hepatitis, and the LENAC score was 4B, that is moderate cirrhosis. And see what happened to this patient. This patient had confluent necrosis. Okay, and this is, all these areas are showing confluent necrosis, so the prognosis was really bad. So what was the final diagnosis? So this is a cirrhosis 4B with activity, and features are consistent to autoimmune hepatitis, with submassive hepatic necrosis. Okay, so what we learned from this case? So we learned that you have to analyze the cirrhotic livers more critically to provide prognostic information. Okay, but this has to be done routinely. So if there is any question, or should I go ahead?
I think I haven't seen any question till
Okay,
now.
so I can go to the next case.
Yes.
Yeah. So this is case number 3. This is a 29-year-old male, non-alcoholic and non-smoker, and BMI is towards the upper level, 29, and AST is 80 and ALT is 66. They are both marginally increased. ALP level is also marginally increased, and liver biopsy for opinion.
Hello?
Yeah. I am opening the scan slide.
Okay.
So now it has opened. I will go into slightly higher power. What you can see, these are the multiple good course of liver biopsy. And if we go into slightly higher power, in this power only, what else we can see there are a lot of macrovesicular steatosis, okay? And in this low power only, you can determine very well what is the distribution of the fatty change. See, these are the portal tracts. Here there is another portal tract. What you can see, all these fatty chains, they are actually away from the portal tracts. So you can say that these are involving zone 3 and zone 2. And in this medium power also, we cannot see any fibrous bands which are connecting the portal tracts, or they are not crowded together. So architecture is possibly preserved in this case. We'll go into high power into the portal tracts, and you can see in the portal tracts there is mild to moderate inflammation, some neutrophil, occasional, this is a patent bile duct, and occasional lymphocytes are coming out of the portal tract. So there is mild interface hepatitis. So as soon as you identify mild interface hepatitis, that means there is changes of mild chronic hepatitis. Okay, here the inflammation is moderate, but there is no lymphocytic cholangitis into the bile duct, and here also you can see occasional lymphocytes are coming out. So this is mild focal interface hepatitis. There is some spotty necrosis focally, and these are all macrovesicular steatosis. You can see the pushed out nuclei, and importantly, what you can see, some of the aniide or clear cytoplasm, nuclei, what we call as the glycogenization of the nuclei. So this may indicate metabolic change in the liver or in the patient. This is another portal tract. There is not much cholestasis. Focally, we can identify, see in the portal tracts, there are some epithelioid cell granulomas, okay, and as well as some giant cells. And this is a immune granuloma because they are surrounded by dense scarf of lymphocytes. There is no necrosis. Okay, so this may be the additional finding. This is one focus where you can see at the center there is one fat vacuoles, and that is surrounded by some lymphocytes and histiocytes. So this is what is called lipogranuloma. Lipogranuloma is not like a tubercular granuloma what you see. So it is surrounded by inflammatory cells, fat vacuoles. This is spotty necrosis. So whatever picture we have seen till now, it may indicate that there is chronic hepatitis, there may be some metabolic change, and also there is significant macrovesicular steatosis, which is possibly involving about 80 to 85% of the course. There is some additional granulomatous change. There is not much fibrosis. So I will shift to my presentation, and the pictures I have already shown you, so I can skip this. You have to remember, you should not forget this slide. So the inflammation was moderate or mild or moderate in most of the areas, and I told you in NASH, if it is uncomplicated, and in chronic hepatitis B, the inflammation will be towards the lower side. What is matching with this slide, This is the other liver biopsies, not from these patients, just to show you the classical distribution. This is the centrizonal or zone 1, zone 2 distribution of the macrovesicular steatosis in the classical NAFLD. This is actually a alcoholic liver disease. Here also you can see this type of classical distribution. They can be regular or they can be also diffuse. I have chronic hepatitis C. I have already told you the fatty change is usually irregular, and in metabolic liver disease, like in glycogenosis type 1, where you also can see a lot of macrovesicular steatosis, the changes can be diffuse like this. So based on that, you can remember this table. So zone 3, zone 2 distribution, like what we have seen in this case, we have to consider if it is NASH, or it can be alcoholic steatohepatitis, or you have to know if the patient was given steroid in recent years or recent days, or there was any surgery which may have implicated or may have caused this. I have described how the lipogranuloma look like. You will see in the center fat vacuole, they will be surrounded by lymphocytes and some of the histiocytes. Somewhere you will see central hyaline sclerosis in your NAFLD cases. And this is about the granuloma. This is non-necrotizing. This is portal granuloma. Always remember, granulomas you can see in infectious causes like sarcoidosis and tuberculosis in the liver. Though they do not have any classical site of involvement, but most of the sarcoid granulomas, they are discrete and well formed and seen in the portal tracts, and most of the granulomas of the tuberculosis, you can see necrosis. They are loose granulomas, they are larger granulomas, confluent granulomas, and they are mostly seen in the hepatic lobules, but they can also be seen in the portal tracts. But you must not forget, if the patient or must ask to the clinician that if the patient was getting any drugs or medicines. Like you should remember that in all your ATT, the components of the anti-tubercular therapy, or the patient who is from the neuropsychiatric wards who are getting phenytoin, diazepam, chlorpromazine, they also can show you this type of granulomas, okay? And very commonly, you can see talc granuloma in the portal tract. Talc granuloma is basically seen in the chronic drug abusers, or you can see from the other heavy metals. So you must not forget to work up this further with ZN stain or with retic, and you have to ask your clinician if the patient is getting any medicines or not before you write down the report. Here, the empty stain, you can see that there is not much collagenization, but there is mild irregular thickening of the central vein, what you can see. So we have to do NASH CRN staging, grading and staging, that is based on the percentage of steatosis, the extent of the lobular inflammation and hepatocyte ballooning. The case I am showing you, there was many balloon hepatocytes. The lobular inflammation you have to assess in 20x objective in NAFLD, okay? But on the other hand, in chronic hepatitis B and C, you have to count those area of spotty necrosis in 10x objective. Remember that? So if you see in this case, there are around 2 or so, so we'll give 2, and the steatosis are involving more than 66%, so the score will be 3. So total there will be 3 plus 2 plus 7, so it will be 7 by 9. And what is the stage? Stage is, I told you, when you are not seeing any septae, you should not entertain this. So here there were mild collagenization on empty stain also, empty stain only, not on HNE. So if you see centrizonal mild fibro collagenization with MT, that is 1A. If you can identify that with your HNE stain, if it is central vein is markedly thickened, that is 1B. And if that is some fibrosis of the portal or periportal area alone, that is 1C. If both are showing fibrosis, then it will be 2. There will be septae, that will be 3, and cirrhosis will be 4. So accordingly, this was graded and staged, and I just retic will not add much to this case because there was not much septae or something. But see this granuloma appearance. What you can identify, all these granulomas are retic rich. Okay, this is also not a very specific finding, but you can see all the granulomas are surrounded by multiple reticulin fibers, and they are also branching inside the granulomas. So they are called retic rich granulomas. They are usually seen in sarcoidosis, and in tuberculosis, as the granuloma is very destroying kind of granulomas, these reticulin fibers are usually degenerated, and we do not see much of reticulin fibers residual. They are called retic-core granulomas. So based on that, our final diagnosis was possibly this is NAFLD with portal non-necrotizing retic-rich discrete granulomas, and we then suggest, you cannot tell very definitely, but possibility of coexisting sarcoidosis or DILI could not be ruled out, and they should work this further to reach to a specific cause of that granuloma. So what we learned from this case that the site of the granulomas, though there are some suggestions that if it is portal granuloma, they can be sarcoid, if it is lobular granuloma, they can be tuberculosis, but it is not very always etiology specific. Please remember that. However, in conjunction with the clinical detail and further workup, like I told you, you have to do ZN stain, you have to correlate with chest X-ray, you have to call up your friend, what are the other findings, then you can identify a hidden etiology. Okay, so this is all about case 3. Any question?
Yes, the lymphocyte-rich granulomas are not the lipogranulomas, no?
No, ma'am. Lipogranulomas are, I showed you.
Lymphocyte poor.
Yeah,
Yes.
see, the granuloma, what we discussed in sarcoidosis and tuberculosis, they are well-formed granuloma by the epithelioid cell. But lipogranulomas are not epithelioid cell granulomas, they are histiocyte granulomas. And here in the center, you will identify one fat vacuole, and they will be surrounded by classical foamy histiocytes, not your transformed histiocytes, and some lymphocytes. So it is not very well-formed, and you will miss very commonly this type of granulomas.
So the granulomas we are seeing here, they are not lipogranulomas or cholegranulomas, which we often get in the liver. So the possibility of the sarcoidosis or the tuberculosis is still there, no?
Yeah, the epithelioid cell granuloma, what I showed, the classical well-formed granuloma, based on that we kept a possibility of sarcoidosis. We cannot rule out obviously tuberculosis, but this type of lipogranulomas were also there, which is not that well-formed and not epithelioid kind, so that can be seen in NFLD.
NFLD.
Yeah.
Yes, that is going with the NFLD. Yes.
Exactly.
Okay, thank you.
Can I go to the next one?
Yes, please.
And please tell me if I am I'm exceeding time, okay? So this is case 4.
That will be told by Dr. Nadeem.
Okay.
Okay.
So I am going to case 4. Case 4, there is no specific history. This is actually related with the case 3 only. So I will go quickly and show you very quickly. Yeah. So I will save some time in this case. So very quickly, we cannot see any distortion of the architecture, but there are multiple of such circumscribed lesion all over the liver. Will go into high power. And see, these are the portal tracts, which is showing some inflammatory cell infiltrate and interface hepatitis. However, within the lobule, there are multiple of such granulomas. There are also immune granulomas. You can see the lymphocyte cuffing, and see, these are actually epithelioid cell granulomas with central necrosis. I just kept this case to show you and give an impression how the tubercular classical granulomas look like. This is actually a case of disseminated tuberculosis. You can see the granulomas are present somewhere in the portal tract, but most commonly they are situated in the lobules. So in my experience, this is a portal granuloma, okay? And in tuberculosis also you can see cholestasis and all those changes because of destruction by these portal granulomas, but they are usually or more commonly you will identify granulomas in the lobules, and the granulomas are multiple, they are large, and they can be confluent. That means they hug each other, and this is a classical Langhans type of giant cells and central necrosis, okay? So, and there was not much fibrosis, and see, we were given another biopsy from this case, and the biopsy was from the lung. See, Just to show you, in the lung also you can identify there is exudative phase of inflammation and there is few large necrotizing epithelial cell granulomas, because this case was suspected to have disseminated tuberculosis and this is confirmed. I just kept this case to show you the pattern of the granulomas we see in tuberculosis, and as it is a destroying kind and it is expanding granulomas, if you do reticulin, the reticulin surrounding the granulomas and inside the granulomas will be the fibers will be less, so they will be retic poor. But I lost that reticulin stain, so we'll save some time and we'll go to the case number 5. So case number 5, the patient is non-obese and 45-year-old male, presented to the medicine OPD with altered sensorium, jaundice and ascites. Okay, there was no known disease, serum transaminases is present, ALP is high, COVID-19 rapid antigen test was negative, and patient died on day 3 and post-mortem biopsy was taken for etiology. So multiple good length liver core biopsies were taken. You must know, and you have been already taught, I think, that a good liver biopsy should be at least 1 centimeter in length, but ideally if you talk about, they should be 2 centimeter or more in length, and there should be at least 10 portal tracts which are well identified. So this is a adequate liver biopsy. So what we can see in this low power only, we can see the portal tracts are markedly expanded and possibly they are being joined by fibrosis or fibrous band. They are joined, the two adjacent portal tracts are joined to each other and they are forming complete nodules. There are some inflammatory cell infiltrate here and there. So most of the liver is showing almost similar change. So there is no doubt that we are possibly seeing a cirrhotic liver and there is distortion of the architecture. As we have come to the higher power, we can see this is a normal liver. Okay, and here the hepatocytes are more eosinophilic, they are falling apart. So these are basically areas of necrosis. Okay, this was also post-mortem biopsy. See, this is the zone of preserved hepatocyte, this is a portal tract, some interface hepatitis, and here you can see there is extensive centrizonal necrosis. There is extensive centrizonal necrosis. So we'll see what else we can see. So there is extensive in this portal, surrounding this portal tract, there is marked ballooning. If we go into high power, within these ballooned hepatocytes, you can see there are multiple eosinophilic ropey fibers like this. What are they? They are actually mallory-dengue bodies. Okay, here you can see lot of necrosis, and in the zone of, so there is interface hepatitis, there is no doubt. But see, whenever there is mallory-dengue bodies, because as they act like a foreign antigen, you are supposed to see polymorphs. The polymorphs were quite less prominent in this case. Here, see what is happening. The fibrous bands, they are irregularly creeping into the hepatic lobules, what we did not identify in previous hepatitic causes, okay, or hepatic biopsies. And you can see obviously there are some fatty change. These are small vesicular steatosis. These are not microvesicular steatosis, that will be bubbly in appearance. These are small vacuoles of macrovesicular steatosis. You can see bile duct. Okay. So these are spheroid-laden macrophages. But in this zone, the fibrosis is really creeping and going inside. So we can identify both some acute changes of acute decompensation and both chronic changes. Here this is not very much focused, but you can identify the mallory-dengue bodies. Okay, so I'll go to my clicked images. So I have shown this is showing cirrhotic changes. See this portal tract or septae, what you can identify, some of the bile ducts are showing mild regenerative change, and there was occasional neutrophil, not much, and there are rest of the lymphocytes. There was interface hepatitis, I showed you ballooning and malodorting bodies, and these are very prominent and occasional neutrophil around the malodorting bodies. Otherwise, this is called neutrophilic cephalotosis, and this is the showing the ballooning and malodorting bodies, which can be highlighted by your empty stain. So malodorting bodies, if you see too many, like in this case, okay, so what you have to think, in addition, if there is pericellular fibrosis or creeping fibrosis in the periseptal area, you have to think of alcoholic steatohepatitis. Okay, I showed you NASH. In NFLD also you can see an occasional malodorting body like this, but not up to this extent. So numerous malodorting body, if you see in a liver biopsy, you have to think of two conditions. One is, can it be alcoholic steatohepatitis, and other is Indian childhood cirrhosis, what we don't see nowadays much commonly. Or okay, so always remember, you have too many malodorting bodies, your differential diagnosis will be alcoholic steatohepatitis or Indian childhood cirrhosis. And in any condition, may it be extrahepatic biliary obstruction, or may it be NFLD also, you can see an occasional malodorting body. Okay, so now I showed you this macrovesicular steatosis, very regular, and this is the creeping fibrosis, what we call actually pericellular fibrosis. They surround all these individual hepatocytes, and there are some cholestasis, very focal canalicular cholestasis. It also have some importance in alcoholic hepatitis, and this is, so if you see this combination, the combination of pericellular fibrosis, the combination of numerous malodorting bodies with neutrophils around them, and steatosis, so your consideration should be towards the alcoholic hepatitis, and you have to look into your form, and you have to basically talk to your clinicians. And always, as a pathologist, always don't forget to look into the clinical detail very minutely, because whenever there is a hepatic change, the liver is being degenerated or hepatocytes are being degenerated, the AST and ALT ratio you must always calculate. The normal is 0.8. If it is more than 3 or more than 2, then you should always think of alcoholic hepatitis. But if the AST-ALT ratio is very high, maybe more than 6 or more than 10, then the possibilities of severe degeneration of the hepatocytes, like your viral hepatitis, like your autoimmune hepatitis, okay, or when there is severe degeneration rapidly, like your acetaminophen toxicity or ischemic injury, diffuse. So all this condition, so this ratio will be further higher. So don't forget to look into these clinical details. That will also help you to reach to your diagnosis. Now I will show this table. This was published in 2004 by the Altamirano et al. Their group. They basically tried to see what are the histological picture in chronic autoimmune or alcoholic hepatitis, which is related to the prognosis of the patient. Okay, so they found that whenever there is bleeding or fibrosis or cirrhosis, those patients do badly. When there is ductular or canalicular cholestasis, like in this case, those patients also show poor prognosis. When the polymorphonuclear infiltration is mild, normally if you see too many malodorting bodies, the polymorph will also be very commonly seen. Okay, but in this case the polymorph was mildly or occasionally seen, so that is a bad feature actually. If you don't see many polymorphs in your alcoholic hepatitis, and if you don't see megalomitochondria, that is also a feature of poor prognosis. And they could not found any correlation of the prognosis with the number of malodorting bodies they identified, or the extent of the lobular fibrosis or amount of steatosis in their biopsies. So based on this, or the odds ratio, they applied the power and they made alcoholic hepatitis histological scoring, or AHHS, which is very important for prognostication in these patients. I am showing you, I chose all these cases. They mostly showed the end state changes and grave outcome. Mostly they are post-mortem biopsies. Just to tell you that apart from diagnosing cirrhosis and all those changes, you have to do something more. Like in this case, you should do alcoholic hepatitis histological scoring based on the fibrosis stage. I told you, as the presence of cirrhosis or presence of advanced fibrosis is a poor prognostic marker, they gave it 3+. Bilirubinostasis, if there is canalicular or it is canalicular, ductular, or hepatocellular, then gave it 2+. Polymorphonuclear lymphocytes, if there is no lymphocytes or mild neutrophilic infiltrate, there should be more. Okay, so they give 2+, and megalomitochondria, when they could not identify, they also gave 2+. So in this case, our score was 3+, 1+, 2+2. It was 8 out of 9. So that is really bad. And you can see the result. There was confluent hepatic necrosis or submassive hepatic failure in this patient. So what was our final diagnosis? Our final diagnosis was this is chronic alcoholic cirrhosis. How we made that? Because the features were very classical. With activity, I told you whenever there is lot of inflammatory cell infiltrate in the fibrous septa, you should utter this word cirrhosis with activity. AHA score, I told you why you should do. It is 8 out of 9 in this case. With you should also identify what are the other changes. We identified there is submassive liver necrosis. So what we learned from this case, identification of cirrhosis is not enough. Histological prognostic scoring should be done. Okay, like in this case. So any question if we have?
Still no, I haven't seen any question.
Okay.
I don't know whether Dr. Nadim, is there any question on your?
I'm sorry.
No, please carry on.
Okay, so I'm going to, this is actually really an interesting case what I'm going to show. That's why I basically clicked a picture of the form. See, with this you can correlate all the previous cases what you have identified. Okay, so this was a 37-year-old female. Just to summarize the history, the patient was actually a male patient, and there was congenital adrenal hyperplasia, and obviously there were estrogen. The patient developed phenotype of a female, and she chose to do sex change surgery, and that was done almost around 18 years of her age. She present to one of the hospitals in South India with presence of ascites and jaundice. It was 4 or 5 months back, and they identified active hepatitis, and that was not being controlled with medicines, and serum bilirubin was 2, and the patient was then chose to came to Delhi and came to our hospital. In our hospital we found the viral markers are negative. ANA was 1:100, IgG was almost near 2, and anti-LKM and asthma was negative, and there was endoscopic varices were also present. That means the patient had features of portal hypertension. They identified active hepatitis. And this presentation was just 4 or 5 months back when the patient landed in New Delhi, and there were some features of autoimmune hepatitis what we can identify. So let's go to the case. See, in this low power only you can identify this is a adequate biopsy with such a long course, multiple cores. But what is very prominent is there is distortion of the architecture. In the low power only you can identify there are thick fibrous bands. Most possibly these are all progressive fibrous band. There are a lot of inflammation with lymphoid aggregate, and they are connecting each other and forming varying size hepatic lobules. What else we can see? We can see there is a marked focal sinusoidal dilatation. Some of the branches of the portal vein are also dilated in this low power. So obviously low power diagnosis is possibly cirrhosis with activity. And if we go into high power, what else we can see? The inflammation is really dense. There is dense paraseptal interface hepatitis. See, along with they are coming out and they are forming some acidophil bodies here and there is spotty necrosis also. All these sinusoids are dilated. These are the bile ducts. You can clearly see the lumen. These are the ductules. Where you cannot see the lumen, I will see more. What else we can see? This is a hepatic artery. See, there is focal ballooning, and in this low power only you can identify there are plasma cells which are there. Okay. And see this bile duct, they are also showing a marked regenerative change that I told you that they indicate that the bile ducts are injured at places. There are some polymorphs here and there, spotty necrosis, okay. This is a spotty area of spotty necrosis. So what do you think? Whatever we have learned till now, the inflammation is quite dense and forming focally lymphoid aggregates. There is regenerative change in the bile duct, and obviously if we go into high power and give time to this biopsy, we'll find active lymphocytic cholangitis at places. I have showed you an occasional one or two plasma cells. And so what do you think? Can it be autoimmune hepatitis? As we are not interacting, but I think you will agree to me that it can be autoimmune hepatitis. But I will bring on notice to the another thing. In addition to this inflammatory cell infiltrate, see at places you will see hepatic artery like here, but adjacent to hepatic artery within a 1 millimeter diameter, you should see a portal vein branch. It is not there. See the difference of the portal, the difference of the inflammatory cell infiltrate. Here the fibrosis is more denser, here it is loose, and it is more bland here, and you can see multiple recanalization, and you are not seeing portal veins active, which are actually dilated structures, okay. So this area appeared to me that, see, here is also you can see hepatic artery, and this area is bland. So it was appearing that there is obliteration or fibrosis of the portal vein, in addition to all these inflammatory changes which what we see, what we saw actually. And sorry for this, and I think it has hanged, and I will go to the clicked images because the scanned image was hanged. And so I will just tell you, so I told you there are two types of changes. One is dense inflammation with interface hepatitis and all features like autoimmune hepatitis. In addition, where the portal veins were there, branches were there, they are markedly dilated, and other areas they were appearing thrombosed and recanalized. These are the hepatic artery, and there was associated changes, okay. And there was not much fatty change you can see, and not much cholestasis. So we got this biopsy. This was done at our center. This was not the one what was done in the one of the South Indian hospitals. So we did not get that initially, okay. So these are the dilated portal vein branches, and these are the areas of bland fibrosis. This is the recanalized and thrombosed portal vein just adjacent to the hepatic artery, and here also you can see bland nature of the fibrosis. And the other areas, the inflammation was very dense, just like your autoimmune hepatitis. These are plasma cells. You can see the plasma cells are there, okay. There are multiple plasma cells here also, almost forming clusters. Plasma cell clusters are more, you should think of autoimmune hepatitis. And see the type of collagen on the special stain also differs. In this area, I always found in the vascular liver diseases, it shows this type of reddish hue, okay. So this is loose, there will be not much inflammation, and the color will be like this. On the other hand, hepatic collagen, they will be more denser like this. We also performed DVG just to see if we can identify residual vein outline, but we could not. So we have seen obviously cirrhosis with activity. So what is the etiology? Initial etiology, it is autoimmune hepatitis or it is drug induced liver disease, because the patient was performed sex and surgery and she was on ethyl estradiol, okay, or estrogen supplementation. You should, when we looked into the literature, we found that estrogen or ethyl estradiol can induce autoimmune hepatitis like picture in the liver very commonly, and there are few case reports available. And you should not forget that autoimmune hepatitis can be, there can be three type of autoimmune hepatitis relationship with the drugs, okay. AIH with DILI, that means the patient had always autoimmune hepatitis known. If you have given some drug, the autoimmune, there can be flare of the autoimmune phenomena or picture, so that we call autoimmune hepatitis hepatitis with DILI, they both are coexisting. Now, drug-induced autoimmune hepatitis, which is likely in this case, but then the autoimmune phenomena will be not clinically known. Okay, and if you give some drug like ethyl estradiol in this case, the picture, the autoimmune-like picture will be set in, like what you are seeing. And other feature is the systemic immune-mediated drug-induced liver disease. That is, you will see most of the systemic organs, there will be features of rash and thyroiditis, all features of systemic autoimmune activation. Okay. So in this case, what we thought in this biopsy is that there is cirrhosis with activity. We thought possibly it is consistent with autoimmune hepatitis with obliterative venopathy, because it is also known that your estrogen supplementation like OCP and other, they can cause endotheliitis and sinusoidal obstruction syndrome, or they can really also cause NCPF or non-cirrhotic portal fibrosis, like what I showed you. Those type of changes can be seen, but we are not sure. We gave this diagnosis with a query. Okay, now see how the scenario or the picture can be changed. After a few days, I got a call from the hepatologist. Now they brought, because their feature was, because I reported it is a cirrhosis with activity, and for just 5 months back the liver biopsy is reported as acute hepatitis. How it is possible? See, these are the liver biopsies, and we can see there is no cirrhosis. What else we can see? There is some inflammation in the portal tract, interface hepatitis, but see, most of the changes are in the hepatic lobule, so they are not wrong. And some of the ballooning you can see, and there is lobular disarray. Okay, and this time initially the patient was well and she did not give any history of alcoholism, though it was asked. But the patient's relative, when they came from South India, they gave rivals that patient used to take more than 60 grams of alcohol since more than 10 years. Now see, what we are seeing in that biopsy, what was not present in our biopsy was that macrovesicular steatosis. You can see lot of ballooning and lot of spotty necrosis in the hepatic lobules. Here you can see a lot of maluritic bodies. I told you, if you see lot of maluritic bodies is neutrophil or neutrophilic cephalotosis, you must not forget autoimmune hepatitis. Okay, so see, all these are maluritic bodies, too many. And in the portal tract also you can see lot of neutrophil, and the bile duct also, some bile duct changes can be seen in alcoholic hepatitis. And here also you can see there is neutrophilic cephalotosis with maluritic bodies, and there is ballooning. Now here you can see some of the lymphocytes, they are infiltrating the bile duct, but see the pattern of fibrosis. I told you the pattern of fibrosis in alcoholism sometimes can be very classical. That is pericellular fibrosis. Is the Orsin stain, they are bringing out the elastic fibers, and the empty stain you can see there is fibrosis all around the residual hepatocytes. So this is pericellular type of fibrosis. So do remember that this is one of the classical pattern of fibrosis in your alcoholic hepatitis, but sometimes this type of fibrosis may not be identified when there is only when there is already cirrhosis, but the patient has reached to a stage of cirrhosis, then you may not see this type of classical pericellular fibrosis also. So our diagnosis was also this is chronic alcoholic hepatitis. So now if we correlate both the biopsies, see, and I told you in chronic alcoholic hepatitis what you have to do. You have to also do acute alcoholic hepatitis histological scoring, and it was also very high, 8 out of 9 in this case. And so final diagnosis we suggested after correlating that it is a chronic alcoholic hepatitis to start with activity, with query superimposed estrogen induced autoimmune hepatitis and NCPF. I previously told you, whenever there is, as a pathologist, you have to identify multiple pathologies. If there are coexisting pathologies, there are not, because they lead to fibrosis very fast. So this patient actually died after this biopsy, after 1 or 2 months of the second biopsy. And see the great prognosis or end state change brought about by all this combination of changes. One is alcoholism, chronic hepatitis, and that was an autoimmune hepatitis precipitated by estrogen and supplementation, and as well as there was thrombosis of the portal vein and obliteration, that is NCPF like changes. Okay, so this case is a very important case. I wanted to show you, and you should remember that drugs can change the course of the liver diseases rapidly, and multiple pathologies can lead to end-stage liver disease very fast. And apart from causing the direct changes, drugs can precipitate autoimmune hepatitis or vascular liver diseases, both of which we have seen in this particular case. So please remember this case. Okay. So if there is any question, do I have any time further, Dr. Nadeem?
Yes.
Achha, I have two more cases because some related changes I wanted to show you. So if there is no question, I can go to case number 7. So case number 7, this is a 28-year-old male presented with abdominal pain, jaundice and pedal edema. So there are features of portal hypertension, some of the chronic liver diseases. Also there were seizures and loss of consciousness. Okay. No previous episodes were there. No reported fever. The non-alcoholic and non-smoker patient. There are also tremor, and ALT was 46 and AST was 140. So if you work out the ratio, it will be how much? It will be more than I think 3 or 4. And alkaline phosphatase is normal. Bilirubin was high, and clinical diagnosis was acute and chronic liver failure. ACLF means there was known chronic liver disease in the patient, and there is some acute decompensating cause either in the liver or systematically. So that is called acute or chronic liver failure. Okay. In this case also you can see acute decompensation features like there is seizure, tremor, loss of consciousness, jaundice, and this was a known case of chronic liver disease possibly. That's why they thought it is ACLF, and they thought what would be the etiology. So I'll go to the scan case. See very quickly, this liver biopsy, I don't know why it is not clear. My computer is becoming slower now. This liver biopsy is showing also distortion of the architecture and lot of inflammation. See, these are the hepatic nodule. I will help you to quickly see. And this is another nodule. This is the fibrous septae, densely infiltrated by the inflammatory cells. We'll go into high power. We can see some cholestasis now, and the inflammatory cell is dense like this. So we should not forget some other causes like chronic hepatitis B or NFLD alone. So it can be the other causes, chronic hepatitis C, or it can be autoimmune. And see, there are bile ductules, because I told you ductules are seen at the junction or near the interface hepatitis, but some of the ductules are dilated and they are showing cholestasis. In the hepatocytes also you can see cholestasis. We'll go into high power and see inside the hepatocytes you can see spotty necrosis. There is canalicular and intracytoplasmic cholestasis, features of regeneration, and irregular macrovesicular steatosis you can see. Okay, and there is a lot of inflammation and fibrosis. I have told you there is some ductal cholestasis also, and this is actually a ductule which is dilated. Normally you are not supposed to see the lumen within a ductule, and when the ductule is dilated and you see ductular bile plug, that is one of the diagnostic feature of sepsis related changes. Please remember that. And this is the inflammation, and these are irregular macrovesicular steatosis. What else we can see? In this area there is focal confluent necrosis, the hepatocytes. We can see the dropout of the hepatocytes. Okay, so these are the all features what we can see very quickly in this liver. I will go to some of the clicked images. And interestingly, while we were working up the case, we also were informed that during the neuropsychiatric workup, the patient's urinary copper was more, that is 2.4 micromole per 24 hours. Plasma ceruloplasmin was lower than normal, and KF ring was doubtful. There was positive presence of KF ring. So these are clinically one of the diagnostic feature of Wilson's disease, you all know. So these are the clicked images. I showed you there was distortion of architecture, so cirrhosis with activity, no doubt. There was features of confluent necrosis I showed you, and you can see there are a lot of inflammation, but see here also, along with being very dense inflammation, there are multiple plasma cells you can identify, okay? But I will show this is not autoimmune hepatitis possibly, so you have to know the exceptions, okay? And there is a lot of fibrosis, fatty change, and here also you can identify some endotheliitis like feature, which is I showed you one of the histological indicator of autoimmune hepatitis that was also present in this case along with these plasma cells, okay? So we certainly thought this can be autoimmune hepatitis, but the clinical picture was indicating Wilson's disease, what we should do. Now see, here there is a lot of macrovesicular steatosis, and this is a feature of sepsis. And there was confluent necrosis, and this Orsin stain is not very good, but there was granular positivity in the hepatocytes also. So Orsin was positive. So now we have a diagnostic dilemma that if it is a Wilson's disease because the Orsin positivity focally and the clinical picture says so, or there is autoimmune hepatitis because all our feature of autoimmune hepatitis we saw earlier is seen in this case like plasma cell clusters or interface hepatitis in dense inflammation, bile duct changes, and everything actually, okay? But we should not forget that Wilson's disease can mimic autoimmune hepatitis sometimes, especially when the case, when the patient presented with fulminant hepatic failure, okay? It is a known problem. Now see here in this case, it was reported in 2000, they have reported two cases. In one case, there was it was diagnosed as coexisting autoimmune hepatitis and Wilson's disease because they had seropositivity, and this patient has to be treated differently. They were treated with D-penicillamine as well as your immunosuppressive like steroids. On the other hand, in the second case, they thought it is a Wilson's disease, it was a autoimmune hepatitis because of presence of plasma cells, and like all features I showed you, the patient was treated for 2 years. The patient was not responding to steroids. Later it was reviewed, and then revised diagnosis of autoimmune like Wilson's disease was made, and the patient was giving D-penicillamine, and the patient quickly responded, okay? There is another case report I am showing you. This came in 2014. Here also the Wilson's disease just mimic the autoimmune hepatitis in a patient with fulminant hepatic failure. So always remember, presence of plasma cell, endotheliitis, dense inflammation, bile duct injury, this though indicate there is a there can be autoimmune hepatitis. You have to also look at the serology. You have to also look at the clinical picture. In our case, the clinical picture was more like Wilson's disease. There was seronegativity, okay, and the histological picture was autoimmune like. I quickly will tell you what happens in Wilson's disease. You all know copper is taken up by the copper transporter protein, and they are combined with the metallothionein in the cytoplasm, and they are also combined with other antioxidant proteins, and they are brought into the lysosomes. In the meantime, in the lysosomes, what happens, there are receptors which are called ATP7B receptors. This receptor is needed to take this copper into the Golgi zones. This is a Golgi zone, Golgi bodies actually, and within the Golgi bodies they are packed with the cellular plasmin, and when they are packed, only the cellular plasmin can come into the circulation. So, and also remember, your bile comes into the this copper comes into the or drained through the bile, and for that drainage also this receptor ATP7B receptor is needed. What happens in Wilson's disease? There is homozygous or heterozygous mutation of this typical receptor. They are absent. So what will happen? All these copper, okay, they will be stored inside the lysosome. That's why if you do Orsin stain or rubenic acid stain, you will see cytoplasmic positivity, okay? But it is not necessarily, because all these stains, they have very low sensitivity to identify the stored copper, okay? Orsin basically identifies the copper associated protein. It has relatively better sensitivity than rubenic acid and rudanin, but it is not good. So, if the clinical picture is indicating or there is of classical of Wilson's disease, you must not overlook that. Absence of demonstrable copper in the liver is not a feature what you should entertain to rule out a Wilson's disease in such case. When there are classical pictures means I showed you the macrovesicular steatosis, there can be nuclear glycogenization, I will show you another example, and there will be a lot of fibrosis, okay? And what happens when the patient undergo fulminant liver failure or liver failure? These lysosomes rupture and you will see lot of toxic injury because oxidant induced damage of the hepatocytes, okay? And there will be cellular damage like what we are seeing in this case. See, this is another example. So you have to identify Wilson's disease by identifying this combination of features, like there will be dense inflammation, interface hepatitis, irregular steatosis, there will be nuclear glycogenization like this, and there will be lot of fibrosis. The dictum is, if you identify lot of inflammation and fibrosis in a patient with steatosis, in a patient who is aged less than 40 years, you must rule out a feature of Wilson's disease, okay? And also remember, in all your autoimmune hepatitis cases where the patient is showing liver failure changes, you must rule out, at least you should do copper stain and rule out a possibility of Wilson's disease in where you are seeing histological picture of autoimmune hepatitis. Here you can see lot of copper deposition with Orsin stain, and this is the negative control. With Rodanin, similar, same case is showing much less copper deposition, its sensitivity is much less, okay? And also remember why this fatty change occurs in Wilson's disease. There are contradictory reports. Some says that when there is high copper in the liver, there will be severe steatosis, while the other studies show that this fatty change in Wilson's disease is possibly related to presence of this genetic allele, that is the phospholipase domain containing 3 gene, and pediatric age is also associated with fatty change in the liver. So there are contradictory reports, and always remember, to diagnose a Wilson's disease, you should see irregular copper deposition, coarse copper deposition all over the hepatocytes, okay? But in a cirrhotic liver, when the bile cannot be drained, because I told you the bile, the copper is transported with ceruloplasmin into the blood and drained into the bile. So whenever there is cirrhosis, bile cannot be drained properly, you will see the copper deposition around the nodule, periphery of the nodule. So this is, when you see this, the diagnosis is not Wilson's disease, this is cholestasis of cirrhosis. But to call something as a Wilson's disease, you have to see this. And I told you, absence of this copper, if you see classical KF ring and your ceruloplasmin is low and urine copper is more, you should not negate a diagnosis of Wilson's disease. You have to depend on clinical findings. You have to work of all cases of liver fibrosis below the age of 40 years for Wilson's disease. You have to also please look into your biochemical findings. In Wilson's disease also, if you work out a ratio of AST/ALT, if it is more than 2.2, I told you, if it is more than 3, you have to think of alcoholic hepatitis. If it is more than 2 or so, you have to also think of Wilson's disease, okay? Now, ductular cholestasis, I showed you, where you will see at the periphery of the lobules, and these are the ductules actually, and these indicate features of sepsis. So our final diagnosis was consistent with Wilson's disease because the classical clinical picture was there, biochemical findings was there, and we could found some copper deposition with submassive hepatic necrosis, and there was sepsis. So this was the original disease, and this is the acute decompensation. So this does clinically basically fulfill the criteria of ACLF. So what we learned in this case, Wilson's disease mimics autoimmune hepatitis. Autoimmune hepatitis can mimic Wilson's disease. So AIH-like morphology with liver failure, especially in a patient who is less than 40 years of old, you should always rule out Wilson's disease. Okay, I think, is that clear? Yes. So I had two more cases. What should I do, Dr. Nadim?
I think we will stop here. Yeah, because
okay, I think we can stop.
2 hours into
it is almost 1.5 years.
We will have another session. We can have another session.
Another session we can have.
Sometime in March.
It is. Let
I
us
will be happy
digest
to
all
take
the.
any
Let
question
us
if there is any.
let us
Yeah, sure,
digest.
sure.
Thank you.
Yes, yes,
Yes,
please.
yes. Now let Didi coordinate the
Yes,
Yeah,
questions.
please.
Amita Di, you can take over.
please. Is there any question?
There aren't any questions on the YouTube. I don't see any question on the YouTube. If anybody wants
No,
to
I
ask any
can't.
question,
I can't see. I can't see any question.
uh,
But it is really an overwhelming lecture with
Thank you, ma'am.
an exhaustive
But liver
experience,
is
I
a,
guess.
I
It's
find
very
liver always should be taught in a workshop when we have 3 or 4 hours.
yes. Workshop, yes.
Because liver is very
Obviously.
complicated and yeah, it should be
Yes.
slow.
It
Exactly.
has so many functions to do, no?
Exactly,
So
exactly.
it deals with so many metabolic activities and everything. So we must
And
learn it
if you
properly.
see all the liver biopsies in
Thank
low
you.
power, it will all liver biopsies will look just they will be look alike. That is the
Similar,
problem.
similar.
Yes.
And
Yes. And it is also
practice
true that
regularly.
mm,
We should
yes,
practice regularly. Otherwise,
yes, of
it is
course.
difficult to diagnose, sir.
No, actually,
Dr.
Exactly.
Nadim.
taking the liver biopsy is not a very difficult thing, and we can have these special stains. It does not require any higher IHCs or like that. So, with the help of some special stains and biochemical findings, we can have some idea of the liver disease.
And
No?
from your lecture, I learned we should think of overlapping findings. There will be
Yes.
associated factors. If it is
Mm.
autoimmune disease, there should be some history of drug induced or other things or like that. There
Exactly,
are
ma'am.
not only a single entity,
Exactly
single
so.
etiology there. We should
May not
think
be.
of. No, we should
May not be there.
correlate. We should
Very good.
correlate with others.
Very nice lecture.
Exactly.
Thank you.
Thank you.
Thank you,
Thank you,
sir.
ma'am.
Elaborate lecture and clear.
Thank you,
Thank you so much.
Thank
Thank you.
Dr.
you.
Prasenjit. Yes.
Thank you,
Thank
sir.
you. Thank you.
I think you have many more interesting cases in your stock, so we will be enlightened later on.
And
Let
you
us
showed
digest all
granulomas.
these.
You showed granulomas. We are happy to see those
Yes.
granulomas.
So nice granulomas.
Granulomas are there.
Okay,
Thank you,
thank
sir.
you.
Okay.
Thank you
Thank
so
you so
much,
much.
yeah,
Thank you,
Dr.
Dr. Nadim.
Prasenjit.
Yeah.
Thank you, Dr. Nadim.
yeah. Let me
Thank you,
Thank
let
you.
Dr.
me
Nadim.
just conclude here. Let me
Yes.
first thank Dr. Prasenjit Das for taking out time from his such a busy
Thank you.
schedule
It is a pleasure.
and teaching us for 2 hours continuous. He must be very tired, I can bet. And wonderful cases, so very nicely depicted both on live slides as well as on photo micrographs. Wonderfully
Yes,
done, very clear in your concepts and your training and teaching.
yes.
So nice of you to take out time to teach us so many new things and also to tell us, like Didi said, that not only one entity, there are more than one entities which can exist on the
Yes, yes.
same on the same slide, and we have to keep our mind open. Very nicely done. I would
Very
like to
nice.
thank Amita Di for taking out time. She's on a vacation in Shanti Niketan to take out time to be part of this
Thank you.
teaching
And me
process.
also for 2 hours after
Yes, yes. And thank you, Mamta
coming
Di,
from
for
college.
joining us.
Yes.
She's one of the stalwarts of Kolkata.
No,
Thank you
sir.
so
No,
much, all
sir.
of you.
No, sir. I am not follower.
Right.
Okay.
Thank you so much,
Good
everybody.
night.
Thank you. Thank you,
Thank you.
Dr.
Thank you. Thank you. Good night. Good
Good
night.
night.
Bye.
Thank you. Good night.
Okay,
Good night
Dr.
to all.
Dash. See you
Thank you
again.
all.
Yeah, bye.
Bye.
এই প্রকল্পের চতুর্থ পর্যায়ে চলবে আগামী 8 জানুয়ারি থেকে 25 জানুয়ারি কোটিরও বেশি মানুষ এসেছেন এই প্রকল্পে এই প্রকল্পের তাহলে সকল চতুর্থ পর্যায়ের জায়গায় আসুন পাহাড় থেকে পর্বত শহর থেকে গ্রাম উপকূল থেকে লাল নদীর প্রত্যন্ত অঞ্চলে পশ্চিমবঙ্গ সরকার পৌঁছে গেছে পুরানি সরকার নামক দৃষ্টান্তমূলক আন্দোলন করে কি একই সঙ্গে স্থানীয় পাড়ায় আপনার সমস্যা সমাধান